Good evening, everyone. Thank you for joining us tonight for the Musculoskeletal medical update on assessment of lower back pain, part of the Chris O'Brien Lifehouse CPD series. As always, I would like to start by acknowledging the traditional custodians of the land across which we work and meet tonight. I recognize the continuing connection to land, water, and community, and pay respect to elders past, present, and emerging. And I would like to extend that respect to Aboriginal and Torres Strait Islander colleagues who might be joining us tonight. And I would like to introduce our GP facilitator for tonight, Dr. Kenneth Tong, who is a member of Inner West CPD GP Education Advisory Committee. Thank you, Kenneth.
Thank you, Lydia, and welcome everyone. And thanks for joining us after your hectic workday for another session of CPD. I would like to introduce our speaker, our one and main only speaker for this evening. We are very delighted to be able to invite Dr. Etienne to Preez, who's a sports physician working at the Stadium Sports Medicine Clinic, which is a multidisciplinary sports medicine practice in Moore Park in Sydney. He's currently the cup doctor for the Sydney Swans AFL team and has previously worked with a number of other football clubs as well, including New South Wales Water, Sydney Rooster, and the Australian Olympic water polo team. And the topic tonight is regarding assessment of lower back pain, and it's to do with a case study. And I understood our speaker are very happy for any questions, or if you've got any urgent question, please put it in the question box below. And I'll also screen all the questions if I could, and ask our speaker to respond to your queries regarding that. And hopefully you'll enjoy this evening. And without further ado, Etienne, would you please take it away? Thank you for coming tonight. Anyway.
Thank you, Kenneth, and Lydia. Thanks for inviting me to speak tonight. Very, very happy to share some of our thoughts. I'll just make sure I'm sharing the screen properly. Can you see that okay, everyone?
Thank you.
We're good. All right. Yes, I've been asked to speak a little bit on assessing lower back pain. As Kenneth said, I work at the Stadium Sports Medicine Clinic, which is a multidisciplinary sports medicine practice. We see a lot of different musculoskeletal presentations. I've got a particular interest in managing sort of things like arthritis and tendinopathies, but we do see a lot of lower back, as I'm sure all of you see at your practice, and understanding that it's often a difficult area to manage. I thought I'd make an effort at trying to make this as sort of simple as possible. I'm trying to simplify a very complex problem. So this is just an overview of what we'll be covering tonight. So we'll talk a bit about defining back pain, and then how we assess it from a historical point of view as well as physical examination. We'll touch on how do we go about imaging lower backs, and we'll talk about what other investigations may be appropriate, and finally we'll touch on when do you look at referring and who do you refer to. So to get started, I just thought I'd define the scope of the problem. I understand it's probably one of the most common presentations to your general practice would be someone with lower back pain. In Australia, it's more than 80% of the population will have either episodes of lower back pain or they will have persistence of lower back pain. And they can come in various shapes and forms, and they can come as someone with an acute episode of severe pain, or they can come as someone who's had pain for a very long time that's unrelenting. The first thing to always keep in the back of your mind that it generally, 99% of the time, it's not going to be an indication of serious pathology, even though the patients may be quite distressed and in a lot of pain. The starting point is you're probably not dealing with a serious pathology. We'll talk about red flags and what to look for, but at the back of your mind, always remember that being more reassuring with the patient is always going to be useful. I'm sure you've all had challenging patients with back pain. They can be very challenging given how frustrated they could be, how uncertain they could be about what's going on, their sort of fears around what's going on. So to sort of take a step back and try and be as reassuring as possible in how you communicate with the patient and the language you use I think is very valuable with these patients. I think it helps if you've got a very clear way of assessing them and trying to keep it simple and being very clear on what you're looking for and trying to pick up. So when I think of lower back pain, I'm generally thinking of someone who presents with pain in the lumbar pelvic region. So it's generally anywhere from the first lumbar vertebra to the sort of buttock area and even side of legs and down the legs. These are all areas that can be affected by the lower back. So I think lower back, it's rare for lower back only to be felt in the actual lumbar spine. It's more common for it to be felt through that whole lumbar pelvic region. We'll talk a little bit about the difference between acute, subacute, and chronic pain. We'll talk about the difference between sort of episodic and more persistent pain. And importantly, we'll discuss the difference between specific and non-specific pain and this concept of sort of structural versus functional pain. It's all to say this is always a very complex problem. And so my starting point is to try and simplify it from the start and then sort of, see how the process goes. Now, this is quite an arbitrary little statement to put up there, but I think it's useful to know when we talk about pain, and this seems like it's stating the obvious, but the definition for pain is this unpleasant sensory and emotional experience, which is associated with actual or potential tissue damage. And that's from the International Association for the Study of Pain. And in backs, it's very useful to remember that the severity of the pain or even the presence of pain doesn't necessarily indicate the severity or presence of structural damage. And in fact, it's quite common for patients to have relatively normal imaging and still experience a lot of pain. So don't sort of assume that it's psychological or that's made up. You don't need to have tissue damage to have pain. Just the perceived presence of damage or danger to the tissue is enough to create pain and for that patient to suffer. When we talk about acute pain, we're referring to pain that's going on for less than 4 weeks. And the relevance of dividing it into acute, subacute, and chronic is really the processes responsible for pain. So if we're talking about acute pain, generally, most of the time there'll be some activation of nociceptive transducer. So in other words, the sensors in that tissue are being stimulated at a threshold enough to generate pain. And so usually there is some element of tissue damage or inflammation or pathology going on there. As you get to sort of subacute pain, the processes start to change. And then the reason we sort of have this 12-week cutoff where we start talking about something as chronic pain is because generally that is a time frame where you would expect for injury to have healed. So if someone's had an injury, you'd expect the pain to, the injury to have healed within those 12 weeks. So the pain that persists beyond that generally means that there are other processes at play. And these other processes, we're referring to the sort of central sensitization, and we'll talk a little bit about what that means. But essentially, it means that the tissues are becoming sensitive even though they're no longer being damaged. And this sensitization process is very strongly influenced by external factors. So things like stress, emotions, fears, beliefs play a very big part in amplifying or dampening down the degree of sensitization someone's experiencing. So that means that you're going to have to take a little bit more of a holistic approach to these patients. You can sometimes get specific causes of pain that can persist. So not everyone with chronic pain has sensitization, but we'll talk about how we're going about trying to find the group that have specific causes that are treatable versus the sort of non-specific group that I'm referring to here. This is just a little diagram that sort of outlines that. So in your acute phase, your tissues are getting injured or potentially injured, and the nerves take the message up to the brain. The brain sort of interprets that data, and it basically creates that unpleasant sensation, which is pain. And the output is that the patient will respond in terms of their behavior, and there's also some altered physiology. So this is just an example of that sort of interplay of environment on the pain pathways. So I thought we'd use a case presentation to sort of guide us through this assessment process, and we'll keep referring back to this case as we go to sort of see if we can figure out what's going on. So I think this is a pretty typical type of presentation. You have a 22-year-old male patient who works as a carpentry apprentice, and he's presented to your practice complaining that for the past 4 weeks he's had quite severe lower back pain. He rates the severity at about a 6 out of 10, and it's severe enough that he's not been able to work for the last few weeks. He sort of mentions that the pain is generally felt in the middle of his back, but seems to be referring down his right leg, and he denies any preceding trauma or any mechanism of injury. It seems to have come on quite insidiously. So I'll take you through what my approach to any patient with lower back pain is. So the first question I'm trying to answer is, am I dealing with someone who's got specific structural issues causing their pain? And we'll go through each of these categories separately. Am I dealing with someone with more non-specific or mechanical pain? Or are we dealing with someone with some sort of serious underlying pathology? So that's always the first question I try and answer. Now, it's worth remembering that more than 85% of your patients, 85% of the patients will fall in that non-specific group. So the non-specific group will be the most common, and there are a number of reasons why they could present with pain. It could be due to degenerative processes affecting the discs or the facet joints. It could be due to something like spondylolisthesis. Could be due to a herniated disc. Could be from a muscle strain. Could be from injury to the ligaments. And it could be due to the sacroiliac joints having dysfunctional pain. So when we're dealing with someone with non-specific pain, we're essentially saying that they have some sort of nociceptive generator, and that could be the joints, the ligaments, the disc, the muscles, the nerves. But it's very difficult to make an accurate structural diagnosis because the problem with all our modern means of imaging is that there is no pixel for pain. There are some experimental type imaging modalities where you may be able to look at sort of fMRIs, but for the most part, we can look at scans and we can say what doesn't look normal, but we don't actually have a good test that reliably will show what hurts. So it's always worth keeping in mind what the potential pain generators is, but I would always caution against making an overly confident assessment as to exactly where the pain is coming from. And I'll talk a little bit about it, what are the patterns we see, how, when do you suspect it's more the disc, when do you suspect it's more the facet joint? But I think as a general rule is treating them as sort of non-specific pain, being a little bit more holistic, but more reassuring, and not trying to be too definitive in saying that structure or that structure is the problem, because more often than not, our theories are wrong, and it's very hard to prove or disprove these theories. So we tend to take a more modern biopsychosocial approach to these sort of patients. The second group of patients is what I would define as sort of structural specific pain, but it's still mechanical. So these are the patients with things like spinal stenosis. So either they've got narrowing of the spinal canal centrally, and they're getting sort of central spinal stenosis, or stenosis of the neural foramen where the nerves exit. And these patients will typically present with a very classic story of neurological type pain, pseudo-claudican pain. They'll have pain when they walk, and as soon as they stop walking, the pain will go away. And generally, you can correlate their clinical findings quite accurately with their imaging findings. So that's an example of a really structural presentation. The other group that's the same is the radiculopathy group, which we'll talk about in more detail. So where someone's got a definite disc bulge that's impinging on the MRI, and impinging on the nerve, and you can see it on the MRI, and you can test for it on examination, and the findings correlate quite clearly with imaging. And then patients with compression fractures, your osteoporotic patients, clearly you can diagnose them quite confidently on imaging. And then also your spondylolysis or stress fractures of the spine, you can diagnose them quite confidently. The group there that's a little bit in between is the spondylolisthesis. So a lot of patients, as they age, will have degenerative spondylolisthesis, and it's not necessarily the source of their pain unless it's causing stenosis or unless it's causing a lot of facet joint arthrosis. But this group is a little bit easier to diagnose because, like I said, you can actually examine them and you can correlate that to clinical findings. What I would probably also put in that category is someone with hip arthritis or some sort of hip pathology causing their back pain. So once again, I wouldn't treat them like a typical mechanical back pain. They usually have some sort of specific pathology in the hip joint that, if you manage that, will actually relieve their back pain. So that would be the group to always keep in mind. And the hip can be quite a mimicker of pain. So you can get a patient with hip pathology present predominantly with back pain or buttock pain. So always remember to check the hip, and we'll talk about that a little bit later. The last group that's always worth remembering, and you should always screen for these patients in your first consultation, is the group with specific serious pathology. So this could be anything from neoplasias or metastatic cancers, infections, inflammatory arthritis, visceral disease, so vascular conditions like aneurysms, or gastrointestinal conditions, or renal conditions, and then the other group there would be someone with spinal cord compression or compression of the chorda equina. So these are fortunately a very small group of your patients. It's going to be probably less than 1%. But you always want to screen for these, as obviously they need urgent diagnosis and they'll probably need quite urgent specific care. Which brings me on to the next slide, which is, I think, the most important thing to do in your first consultation is screen for red flags. So red flags is basically symptoms or signs suggestive of these more serious pathologies. And there are a lot of red flags on these slides. I've sort of highlighted the ones that are probably most important, the ones you should never forget to ask about. Anyone with significant trauma, especially your older patients or your patients at risk of osteoporosis, you should always ask about trauma. Anyone with signs or symptoms of chorda equina syndrome, so that is where the lower lumbosacral vertebrae are being compressed, and it can cause bladder and bowel dysfunction. So anyone presenting with new onset urinary retention, overflow incontinence, fecal incontinence, numbness in the saddle region, so sort of between the legs, and anyone with progressive or severe leg weakness, you should be suspicious of chorda equina. Anyone with a strong history of cancer. So of all the red flags, this is probably the one with the strongest evidence for benefiting from imaging, especially someone with a history of breast cancer, prostate cancer, lung, thyroid, kidney, or multiple myeloma. So all the cancers that can spread to bone, basically. Anyone with signs or symptoms of infection, especially if they've got a background history of intravenous drug use or recent bacteremia, or someone who is immunosuppressed, you should consider infection. And then the last ones are probably more sort of relative red flags, like I said, someone with a history of corticosteroid use or risk of osteoporosis, without necessarily a history of trauma. Someone with night pain. I always see night pain as a relative red flag. So especially if someone is young and they report that their back only hurts at night, they probably warrant a little bit more investigating. I think thoracic pain, for some reason, also seems to be a little bit more concerning than lower back pain. And then I think people on the extremes of ages, once again, it's a relative red flag because, of course, they can get non-specific pain like anyone else. But anyone who's really young with quite severe pain, or anyone who's probably older with more severe pain, you start considering imaging. So when you are then, if you've ruled out the red flags and you're then starting to take a history on these patients, I think like any presenting problem, you go through the classic questions. You try and characterize the pain, and we'll talk a little bit about that on the next slide. You try and localize where the pain is. You try and get a sense of whether the pain is very localized, they can put a finger on it, or whether it's generally referred and they have to sort of show with a broad hand where they're feeling the pain. You try and you get a sense of whether there's a diurnal variation. That's particularly useful if you suspect inflammatory arthritis in your younger patients. If they're reporting, an hour of morning stiffness and they're really slow to get going, and they feel sort of better when they're moving and exercising, that can be suggestive of inflammatory conditions. The other one that we see a lot is patients with discogenic pain. They've either had a disc herniation or they might have some radiculopathy. We'll typically find that they feel really stiff in their back in the morning. And that's a product of the discs themselves being relatively fuller or more plump in the morning due to gravity. So when we're upright during the day, the discs actually slowly flatten out and we become a little bit shorter. And when we're lying down, the discs sort of draw in fluid and they plump up a little bit, so it makes us a bit taller. So in the mornings, discs can be a little bit irritable. So getting a sense of whether there's a bit of a rhythm to how they feel their pain is useful. Obviously asking about how the pain started, whether it came on suddenly with a traumatic episode, or whether they've had a history of repetitive overload, either through sport or occupation, or whether the pain's just, we woke up with the pain has come on insidiously. Always worth asking about associated symptoms, especially your neurological symptoms. Do they have any areas of numbness, weakness, pins and needles, etc.? Things that could point you to a specific structural cause for their pain. I always ask about aggravating and relieving factors or postures. So, what hurts? Is it more painful when you're sitting versus standing? Is it more painful when you bend over or bend backwards? Is it more painful when you're running, rowing, etc.? So all of this starts to give you a sense of what the issues may be. We'll go through a little bit of that later as well. I always ask them if they've taken medication, how did they respond to the medication? And then, as mentioned earlier, red flags. I want to spend a little bit of time on characterizing the character of the pain, because I think this is very helpful to understand. I think one of the most common situations you'll find yourself in is a patient comes in and say, I've got really bad sciatica down my leg. And they'll say, I've had this back pain and now it's going down my leg, I've got sciatica. And it sounds like semantics, but when we talk about sciatica, we're generally referring to someone with some sort of nerve root involvement. They've either got radicular pain or they have radiculopathy. Whereas most causes of back pain or hip pain will cause some referral down the leg. So there's different types of pain and they have different characters, and understanding that will often help you figure out what the likely causes may be. So somatic pain is the most common type of pain that we would see in musculoskeletal medicine. So that's pain that's generated by cutaneous, or in our case, deep tissues like joints, bones, ligaments, muscles. And it's generally the activation of nociceptors that cause the pain. And it's typically described as an aching pain, a throbbing pain, and it's generally not very well localized. They may be able to point you in the general area, but most of the time with low back pain, they won't be able to sort of quite put their finger on what the sore spot is, and nor will you be able to find that. That sort of contrasts to someone with a foot and ankle injury, where you can generally push on the sore spot and it'll hurt, and you know exactly where the problem is. That brings us to the next category, which is somatic referred pain. So most of these patients will have the somatic type of pain, but it'll be referring into other areas of the body. So when we say somatic referred pain, we're talking about that aching type of pain, but it's perceived in a location other than the site of the actual pathology. And typically it'll be felt in the limbs. So most commonly the lower limb, and usually it's a little bit more proximal than distal. And we're not exactly sure why people get somatic referred pain. It's probably to do with the convergence of the various neurons in the spinal cord. And then you get radicular pain, which is the classic, what I would describe as sciatica. So radicular pain is is actually when you got these ectopic impulses being generated by irritation of the sensory root or the dorsal root ganglion. So you've typically got something pressing on the actual nerve root, and that's causing ectopic impulses that's being perceived as pain along the distribution of that root. Now, the classic radicular pain is a very sharp, incredibly unpleasant, stabbing, lancing type of pain. And it's usually about, they'll say it's pain in a 5 or 10 centimeter band down the leg. When patients describe more vague pain and they're sort of rubbing over an area, that's not radicular pain. Radicular pain, if you've seen someone with really bad compressive radiculopathy, you'll sort of notice it. It's this really shock-like pain shooting down the leg. You cannot determine which nerve is affected by radicular pain. It could be any of the nerve roots. That's contrasted with radiculopathy. Now, radiculopathy and radicular pain can coexist because it's often the same pathology. But when we say radiculopathy, we are then actually talking about the dysfunction of the nerve because the nerve's actually being injured due to compression. So when we talk about radiculopathy, we're usually referring to the numbness, the pins and needles, or the weakness that someone's experiencing. Now, if you get the combination of severe radicular pain plus radiculopathy, that usually means that that nerve is being compressed, the blood supply around the nerve is being interrupted. So not only are they getting that radicular pain, but at the same time, that nerve is actually slowly dying off. And that means that they generally need sort of more urgent review, urgent referral to, either a sports physician or a neurosurgeon if they have severe weakness. So once again, just there's radicular pain and there's radiculopathy, and then most of what you'll see is probably going to be more that somatic pain referral. Neuropathic pain is a slightly different process. That's usually something we see more in people with specific nerve conditions. They may have had strokes, vasculitis, diabetes, or other sorts of inflammation. And then the final group, I think, sort of second last term I want to talk about is this concept of nociplastic pain. And in back pain, this is more often than not present. So this is when you start getting altered sensation of pain without any clear evidence of actual or threatened tissue damage. So that's where someone might have a normal looking scan, but quite severe pain. So the initial injury may have healed, but they got sensitization of the tissues, and their body or their neurological system is still thinking there's damage to that tissue or potential damage. So it's still protecting that area by making it sensitive. So it's often useful to try and figure out, is your patient presenting with the sort of nervy or true somatic pain, or is it more this nociplastic pain? The clues that it might be nociplastic will typically be things like they've got allodynia, they're incredibly tender to palpate with soft touch. They generally have a feeling of dysesthesia, like the limb doesn't feel normal to them. It doesn't feel like their limb, or they're describing it feels weird. There might be autonomic changes. So when you start seeing those more sort of unusual presentations, it often means that nervous system in that area is being overly sensitized. And sensitization is just this process, as I described earlier, where the neurons are becoming more sensitive, the nerves are more reactive. I find these very helpful in my practice. So I get any patient with lumbar pelvic pain to color in for me. And we'll usually give them this diagram. And the key is that we ask them that if it's a broad or a poorly localized pain, for them to sort of color in the area that hurts. If there's an area where the pain's really sharp, like really focal or sharp, to make little lightning bolts, and anywhere where they get pins and needles to sort of to dot that area. And so I put a few examples here to demonstrate the sort of various types of localization that patients may describe. So the first instance here, most likely it's going to be someone with quite a central cause of back pain. And most typically this will be someone with a discogenic type pain. Either they've had an acute disc herniation, or they may have this more degenerative disc disease or internal disc disruption. And in some cases, facet joint pain can present like that, but often facet joint pain will be a little bit more referred. So if someone's got this really central pain, then I always think a little bit more discy, and I'll ask for other features of discogenic pain, like, is it sore when you're sitting? Is it sore when you're bending over? Is it sore when you're coughing or sneezing? And obviously you'll try and sort of correlate that with what you're finding on examination. The one next to it, yeah, I put in there because that's would be a great representation of someone with radicular pain. So that really like a lightning bolt shooting down the leg and a little bit of pins and needles in the foot. So when they draw that sort of picture, then I do start to think they probably have some sort of nerve root entrapment or a radiculopathy. Once again, these are just examples. I'm not saying that this will always be the case, but just to give you an idea of how I think when I look at these patients. This is probably the most common pain diagram you would see. It's a little bit all over. It's broad across the back. It's a little bit into the right buttock. It's sort of down the leg. There's a little bit of altered sensation. Nothing's really strongly localized. It's all a little bit vague. And this is probably one that I would expect to see with something like facet joint related pain. Someone who's got maybe facet joint arthritis, where you're getting that pain referral pattern. The one next to it is, you'll see this patient is describing more sharp, quite well localized pain in the front of the hip, and then the sort of broad aching pain in the buttock. And when I have that sort of presentation, I'm always thinking of hip related causes. So someone might have arthritis in the hip, which I would suspect would be the case with this patient, or they may have something like a labral tear or some other form of intra-articular pathology. You probably can get a similar presentation once again with facet joint pain, because facet joints can refer around. But those would be the sort of pathologies I'm thinking of, and you wouldn't be thinking of sciatica because it's not really shooting down sort of below the rest of the leg. This would be, I think, if you were lucky enough to get a picture like this isn't an actual patient, that's just a picture I drew. I think you'd probably be lucky. If someone drew that, then you're strongly suspecting that they're going to have some sort of radiculopathy. They've got the classic broad back pain. They've got this sharper sort of nervy pain down the leg, and they're having pins and needles in a very dermatomal distribution. In this case, you'd probably be thinking like your L5 nerve root. This case, that could be, once again, facet joint pain. It could be discy. Most likely, I would think it's probably going to be someone with sacroiliac joint pain. And in terms of playing the odds, if you've got someone in that non-specific group of back pain, historically, they say about 40% will be due to discogenic causes, 40% will be due to the facet joints, and about 20% will be due to the sacroiliac joints. And so when someone's got this pain that's sort of below the belt, it's a bit more sharp in that SIJ region, it's referring down, and they might even get some dysesthesia. You could be thinking sacroiliac joint. And then the last group, they've come with back pain, but they're clearly having pain all over. You'd expect that more with a general pain amplification type condition like fibromyalgia, or you could consider one of your rheumatological conditions. So we'll go back to our case. So you ask a little bit more history, and he said, well, typically his pain's a bit worse in the mornings. It seems to be worse when he's sitting and lifting heavy things, and driving to and from the work site seems to make it worse. He doesn't have any weakness or numbness, but he does have a bit of an aching pain going down the leg. In his family, there is he has a history of psoriasis, and there's a family history of some sort of inflammatory arthritis, which he's not sure with, but he remembers mum saw a rheumatologist many years ago. There are no red flags on history. He's otherwise well. He's generally quite active. He plays cricket on weekends where he's a fast bowler, and he also enjoys playing touch football, so he's very active normally. So at this stage, I think you can sort of already warrant a bit of a guess as to the potential diagnoses. So top of my list, I'd be thinking something to do with the discs, given his age, given his occupation, the fact that he does a lot of lifting, plays a lot of sport. It's not unreasonable to think that he may have some pathology of his disc. He's getting a bit of pain referral down the leg, so potentially there could be a bit of nerve root entrapment. Could be facet joint related, maybe a little bit lower down on the list, but once again, he's active, he fast bowls. That's definitely a potential cause. Could be hip related. He's young enough and active enough that he could have a bit of impingement of his hip. He could have some sort of labral pathology. He could even have some early arthritis if he, say, had hip dysplasia growing up. So keep hip-related pain in the back of your mind. Could have a lumbar stress fracture. He's a fast bowler. He's young. It's a very common injury. And he could have inflammatory arthritis because he's got a family history for it. It could be causing sacroiliitis, which could give you that pattern of pain. So you sort of narrowed it down a little bit now. But as you see, that the differential diagnosis is still quite broad. So I think our next step to try and figure out a bit more here is to move over to clinical examination. Before I move on, just checking, were there any questions so far?
No, we don't have questions at this point. Thank you.
All right. This is probably something that's better done sort of face-to-face to demonstrate the examination, but I'll sort of talk you through it. I think being able to examine these patients is very helpful, and certainly the patients would expect you to examine their back. There probably are some limitations as to how accurately you can diagnose things purely from clinical examination, but it is going to be very helpful in distinguishing, once again, whether it's more specific cause for his pain, more non-specific back pain, and what category does he sit in? Is it more disc or facet joint, or could it be more serious pathologies? So I always start by looking at them. I'll get them to, wear a pair of shorts, and I'll try and pull the shorts to just below the posterior superior iliac spine, so I can sort of see their whole lower back. Female patients, I'll at least sort of tuck their shirt up into their bra so I can see their whole lower back, or I'll ask them to wear a sports bra. And what you're looking for is general alignment. Do they have a significant scoliosis, a significant lordosis or kyphosis? And then what's their posture like generally? Are they quite slouched over? Are they have that sort of lazy recumbent sort of posture? Are they very anteriorly tilted? So you try and get a sense of what their posture is like compared to the perfect ideal. Next, I'll get them to bend forward. So I'll ask them to keep their knees straight, bend forward, try and touch their toes. Most people can't touch their toes. If they are hypermobile, they'll be able to put their palms flat on the ground. Most people sort of get to their mid-shin, and I'll try and document what their range is like at their first presentation. I'll ask them whether it hurts when they bend forward. I'll look at the quality of their movement. Often if patients have been in pain for a long time or they're acutely painful, they'll be very reluctant to bend forward. You'll actually see the muscles gripping to try and stop them from bending. And there's this concept of fear avoidance. If someone's very fearful of their back, they'll often look really awkward in bending forward, or they might not bend their back at all. They'll just hinge at their hip without their spine flexing at all. So you want to see whether those the intersegmental motion, whether they actually flexing or whether they keeping their back rigidly straight or an extension and just bending at the hips. Next, I'll get them to bend backwards towards me. And once again, I'll see what their range is like. Does it hurt? If it hurts, where does it hurt? Is it in the middle, one side or the other? I might get them to do a single leg extension, especially if they're young and I'm worrying about a stress fracture. I think a single leg extension is a really good test to stress those posterior elements. And I'll get them to rotate side to side and flex side to side. Then I'll usually do some functional tests just to get a sense of what their weak points are. I'll get them to do a single leg balance. I'll get them to walk on their toes. I'll get them to walk on their heels just to see if there's any obvious neurological deficit. I might get them to do a single leg squat to see how steady they are through their hip control. I might get them to do a deep squat and even duck walk to see if their hips are sore. I might get them to do a step up, just once again to see what their function is like, what's their strength like. I think if you can get them to walk on their toes, walk on their heels, and take a big step up and they look like they've got good strength, it's a really good screening test for sort of neurological weakness. I think this is really important. Every patient you see with lower back pain, you should do neurological examination. especially if you're concerned about specific causes like radiculopathy. So you're always checking the various myotomes, dermatomes. You're checking the myotomes for strength and dermatomes for sensation. I'll quickly run through the myotomes how I would do it, but once again, something that's probably worth seeing in person. So I would typically get the patient to sit over the edge of the bed with their legs hanging down. I'll quickly tap their ankle tendons and see whether they've got a normal ankle jerk. I'll tap their patella tendon and see if they've got normal knee jerk. And that's sort of a quick screen for S1s for the ankle, L4s for the knee. Then I'll do a quick strength test and just compare side to side. So I'll typically get them to extend their big toes and push down. And if that's weak, it's suggestive of L5. I'll get them to flex their knee, so pull their heel towards their bum. So if they're sitting over the edge of the bed, sort of pull their knee in. And that's sort of a quick test for S1. I'll get them to try and straighten their leg against resistance. That's a quick test for your sort of L4, L3, L4. Then more L3 probably. And then get them to lift their knee up to the ceiling. That's sort of a quick test for L2. And then you can do things like ankle eversion, strength. You can do ankle dorsiflexion, ankle plantar flexion, just to sort of check for those in-between myotomes. But I'll do a quick screen from bottom to top, just seeing if there's any weakness. Then I'll do 2 tests for neural provocation. So I'll do a slump test, which is the one on the left. So essentially in a slump test, you're trying to get the nerves at maximal stretch, and you're asking them whether they feel reproduction of their pain down the leg. Where do they feel it? Is it just tight hamstrings, or actually feeling like an unpleasant pain shooting down the leg? And you compare side by side. So someone with some neural irritation, you'll often find that their slump is positive on one side versus the other. The next test you do is what's called a straight leg or a Lasserg's test. And you're trying to get a sense of how far you can passively stretch their leg out straight before they start to get reproduction of pain down the leg. And if someone's got true sciatica, they'll get that pain going down the leg, usually from anywhere from sort of 30 to 40 degrees. And then particularly if the pain's crossing over. So if you're doing the straight leg raise on the left side and they feel the pain shooting down that right side, that's very suggestive that they've got some sort of major disc bulge, disc extrusion. Then I'll always check their hips. Usually while they're sitting, I'll have their legs hanging over the edge, and I'll sort of twist the hip in and twist the hip out to see what the range is like. And when they're sitting, their pelvis is stabilized, so it makes it harder for them to tilt their body to improve the range. So I think a seated position is a good position to just document how much their hip rotates and see if there's any obvious asymmetries or severe stiffness. Then I'll check their hip range and see whether that provokes pain. So you might take them into flexion while they're lying down, and then you might take them into that flexion, adduction, internal rotation to see whether that provokes pain in the hip and whether it provokes their back pain. And then I'll always palpate over the greater trochanterus. And finally, there's the examination of the sacroiliac joint. Now, this is a sort of a tricky examination. There's a lot of tests described to test the sacroiliac joint. I think the ones that are most important or probably most useful is what's called the P4 test, which I thought I had a picture of, but I don't. So P4 essentially is the patient is lying on their back. You flex their hip up and you apply posterior directed force. So I think the 4 Ps are posterior pain provocation test. I can't remember what the 4th P stands for, but essentially it's just that loading the sacroiliac joints by compressing the hip down. The next one is the Faber test, where you cross the leg over and distract it. And so if they're describing that buttock pain when you're doing these tests, then it is more suggestive of the sacroiliac joint being the source. Palpating the sacroiliac ligaments, as is the case in this slide. The sacroiliac ligaments sort of run from the posterior superior iliac spine in a direction towards the coccyx. So if they sort of really tender over these ligaments, it raises the possibility of sacroiliac dysfunction. So on the top there, that's a example of the Fader test. So he's flexing the hip, he's internally rotating the hip, and he's taking it into that sort of forced adduction. And if the patient's describing that sort of sharp hip pain and pain in the buttock, it's suggestive that their pain could be coming from the hip. Once again, that's just a hip flexion seen from the side. Palpating the greater trochanter in the case of someone who might have a bit of gluteal tendinopathy or bursitis. And then this is a sacral compression test. So you get them to lie on the side, you compress the pelvis from the side, and you ask them whether they feel that buttock pain. Finally, I think all patients expect for you to palpate the spine. This is probably the least useful of all the tests. All that's going to tell you really is if they've got a bit of allodynia. I don't think we can reliably diagnose pathology with by pushing on structures. A lot of, I guess, colleagues and allied health professionals might claim that you can make accurate diagnosis, but I think you can get a sense of what levels are irritable or sore, and there's probably an expectation from patients that someone should at least feel their back. But I think of all the examinations here, it's probably the one that gives us the least information. I think it's useful to test to feel whether there's trigger points. So I always palpate sort of through their back extensor muscles and their quadratus lumborum, and I palpate through the buttock muscles, the gluteal muscles. But what you'll generally find is that a lot of these structures are tender because there's underlying pathology, and all those muscles are just sort of increasing their tone and increasing their sensitivity. And then based on your history, you may choose to also examine the abdomen, have a quick feel of the abdomen, make sure it's soft, there's no lumps. If appropriate, you may look at pelvic examinations. Excuse me. And then for patients with suspicions for inflammatory arthritis, you might do a more general examination. I won't go into this too much because that's a whole topic by itself, but I do think that your yellow flags, the so-called psychosocial, so your so-called yellow flags, which is your psychosocial risk factors, are really important in back pain. So getting a sense of their history with back pain, their context beliefs. They might have a family member who's had back surgery and they've seen, how they've become disabled. Someone might have a lot of anxiety around their back. They might be depressed. They might have poor sleep. I think these are issues that massively influence how patients perceive their pain. So I always screen for the presence of yellow flags, and if someone's got a lot of yellow flags, I'll focus a lot of my eventual treatment on sort of educating them about pain, probably multidisciplinary care with a psychologist or even a pain clinic. So I use the OMPQ questionnaire a lot. For the more straightforward or simple patients, I'll sometimes just do a Keel start back screening tool, which is a 9-question questionnaire that is relatively valid in getting a sense of how high the risk of complexity is. If you want a little bit more in-depth, I do an OMPQ, which is this pain questionnaire. I think it's very helpful for anyone with chronic musculoskeletal pain, but especially for backs, and then especially for your work cover patients. And it's quite a long questionnaire, but it's got a lot of really helpful questions around how much anxiety do you have? Do you believe that you should stop doing what you're doing because it hurts? So there's a lot of useful questions that can then guide some of your other interventions. So after we've examined our case, this is now this young man, we found that he stands with a bit of a lateral shift. So he's sort of leaning over what you might describe as a list. He has limited range with standing forward flexion. Whenever he tries to bend forward, it really aggravates his pain. He does feel a bit better when you get him into extension. His hips examined normally. There's no real pain. You do a slump and a straight leg raise, and it's not really reproducing pain down the leg. You find that his reflexes are normal, his power is normal, sensation normal. And on history, he says he's feeling quite anxious. There's a lot going on at home. He says work can be quite monotonous and strenuous. So we're sort of now starting to narrow down a little bit of our differentials. I think we're sort of comfortable. He probably is less likely to have facet joint pain because he's comfortable in extension. He's less likely to have hip-related pain. Doesn't have any clear features of radiculopathy. But he most likely is going to have some sort of disc pathology. And then you still haven't ruled out stress fractures or inflammatory arthritis. So it takes us to the next section here, which is, what about imaging? Now, there's obviously a lot of education around this, and lumbar imaging is probably one of the investigations that's most overprescribed in Australia, and can actually cause a bit of harm. I don't think it's always benign scanning someone's back, and you can create a lot of fear around what they believe is happening in their back. This paper that was published in 2015, they looked at the prevalence of some of these pathological findings on MRI and how common they are as we age. And essentially what you can see is even from your 20s, there's a lot of things that we'll see on an MRI scan which are not necessarily the source of pain and not necessarily pathological. They might just be normal aging changes, to the point where when you're in your 70s or 80s, most of these findings are pretty much ubiquitous across the population group. So you've always got to, I have a printout of this little table in my consulting room. And before I look at a patient's scan, and certainly before I send them for a scan of their back, I'll always talk to them about this. I say, look, a lot of what we're going to see on this is probably normal for your age. What we're trying to determine is what's relevant. But the things that aren't relevant, you don't have to worry about, because they're as likely to be there in someone who doesn't have back pain as it is in your case. There are some changes, especially in your younger patients, which I do take a little bit more notice of. So if someone's really young, a teenager in their 20s, and they've got significant facet joint changes, that is quite likely then to be relevant to their pain. Not always, like I said, 4% of asymptomatic patients will have it as well, but in the presence of pain that fits the mold, you probably pay more attention to it, versus someone who's in their 80s with facet joint change, where you go, well, that's just normal for their age. I'll run through some of the terminology that gets used when we eventually look at the scans, and then I'll show you some examples of some scans. When we talk about discs, there are lots of different terms, and they all actually mean different things. A disc bulge is, I think, generally accepted not to be a source of back pain. So if we go back to the previous slide, disc bulges occur so commonly in the normal population, and there's been some studies that have shown that the presence of a disc bulge doesn't really correlate with the back pain people experience. Annular tears, so where the annulus of the disc starts fissuring through, either through repetitive sort of wear and tear of it, starts becoming a little bit more associated with pain. So if someone has that classic discogenic nature to their pain, and you're seeing an annular fissure, you still know there's a chance that it could be there coincidentally, but it is probably a little bit more likely to be associated with pain. The ones that are more relevant is when you're seeing a disc protrusion or herniation, or a disc extrusion, especially if there's nerve root involvement. I think then you start getting a little bit more confidence that what you're seeing on the scan is probably going to correlate with what you're finding on examination. And the difference between a bulge and a protrusion is a bulge is just this general sort of flattening, rounding of the disc that from the side you might just see sort of a bit more prominent, whereas a disc protrusion typically starts as an annular fissure, and that nucleus pulposus is trying to get out through the fissure, and so then the disc sort of bulges. And if it bulges centrally, they can get sort of central discogenic pain. And if it bulges paracentrally, it can start impinging on the nerve roots that run next to it. So then you get your radiculopathy. And then an extrusion is once the disc material actually breaches the annulus. So on the scan, you'll then actually see that there's disc material that's come through the annulus. They typically present with more severe pain early on, but anecdotally can often settle a bit quicker because the body actually identifies disc nucleus content as foreign body, and you'll get a more severe inflammatory reaction, and it can actually sort of be gobbled up by the immune cells. And then a sequestration is if you have extrusion of a disc that then sort of gets separate from the rest of it. And that's, just a worse form of an extrusion. I'll just briefly touch on modic changes. You will often see on a scan this pattern of change around the discs, and that's likely due to sort of changes to the subchondral plate of the vertebral end plate. It's not too dissimilar to what people with osteoarthritis in their knees and hips, where they get that little bit of bone edema in the subchondral region. And we think that modic changes are more likely to be associated with pain than some of the other findings on a disc. So if you see modic changes around a disc and someone has that real discogenic type pain, there's probably a little bit more relevance of identifying that. The facet joints are the next structure that we can see on the MRI scan. And what we're typically looking is for sort of arthritic changes. So thickening of the joint, irregularity of the edges, irregularity of the joint surfaces. As I mentioned earlier, your facet joint type of pain, the patient will typically have pain that's worse when they're extending their spine backwards. So it'll be worse with extension type activities like running, tennis, anything where they repetitively bending their back backwards, like yoga, even swimming. So if that's the nature of their pain and you're seeing these facet joint changes, there's probably a little bit more correlation there. The facet joint can also be a source of stenosis. So as in this example, if you get hypertrophy of the facet joint, it starts to narrow the neural foramen, and then you can start getting foraminal stenosis and sort of that neural type of pain again. These are examples of pain maps. So studies that have been done many years ago where they try to measure where patients experience pain from the facet joints. The most common is sort of that band across the lower back, upper buttock, lower buttock, even down the thigh. So you can see facet joint pain can be sort of all over. I had a classic patient today who basically drew this diagram. They drew their pain there, they drew their pain there and there. And it was all sort of on the one side and worse with extension. So once again, we can't ever say with 100% certainty what's going on, but you start to think it's going to be more of an extension type pain like facet joint arthritis. So knowing what we can look for on a scan and knowing what we might see on a scan, the question is always, should we image? There's a lot of good guidelines that say that most people with non-specific back pain shouldn't be imaged. And in fact, it can cause harm. It can increase the cost of healthcare. It can also increase the likelihood of that patient undergoing invasive procedures. And what doesn't get spoken about a lot is it also increases the patient's fear and anxiety around their back. So there is actually harm sometimes to scanning someone, especially if they're already anxious. The caveat there is that often patients expect imaging. If they've been in pain for a long time, eventually someone's going to scan them and then they'll blame the last person who didn't scan them. So sometimes it's hard to keep denying the request. There is some useful handouts there. This one is from the Medicine Wise campaign, something that you can sort of give to a patient to say, this is why I don't recommend scanning it. More often than not, when patients come to me, they've already had a scan, and my job is to try and interpret the scan to them, take a little bit of the fear out of it, and say, look, a lot of this is normal. I don't want you to be too worried, but this could be relevant to what you're experiencing. The other problem with imaging is there's very poor correlation between the severity of changes on a scan and the severity of pain. And so just like arthritis of the knee, just because they've got severe changes to the disc or the facet joint doesn't mean they'll have severe pain. And just because those structures look pretty okay doesn't mean they're not getting a lot of pain from those structures. So once again, there's no pixel for pain on a scan. If you do decide to image, either because there's red flags or because you think it's going to change, significantly change your management of the patient, I think from a starting point, X-rays offer little value and do come with a lot of radiation. So especially in younger patients, I would probably discourage you from using X-rays. I do understand that I'm not sure if it's still the case, but there used to be a Medicare caveat, like if you wanted to get an MRI scan item number for a patient, they had to have an X-ray first. I'm not sure if that's still the case, but I personally never get any benefit from looking at a scan other than, if someone, I suspect, has an osteoporotic fracture or significant spondylolisthesis. CT scan is more useful, but comes with radiation, so I don't often use that. I think in your older patients, especially if you're thinking of more stenosis, it probably is more useful. I think MRI is the gold standard. It does give you a lot of detail. So once again, you've got to brief the patient that a lot of what we're looking at is not necessarily relevant to your pain, but if you are going to image it, it probably gives you the most useful information, and we'll look at some examples. And then CT SPECT scan or bone scans can help localize pain. It's probably the closest thing we've got to an imaging modality that can give you an indication of where the pain is. If a facet joint really lights up on a CT SPECT scan, it might be more relevant. And so sometimes your pain physicians, your interventional pain specialists, they may rely a bit more on the CT SPECT scan. Other investigations, I think, as in our case, if someone's young with persistent pain or they've got a diurnal variation to their pain, you probably start considering doing some blood tests to screen for inflammatory disorders. So ESR, CRPs, always do an HLA-B27 on your young patients, because if it's going to be inflammatory, it's probably going to be a seronegative type arthritis. Full blood count, UECs, rules out infections, usual stuff. Nerve conduction studies, I think, really only helpful if someone has a definite neurological deficit and you're not entirely clear whether it's coming from an entrapped nerve root, like a radiculopathy, or whether it might be something more peripheral, or whether it could be a more systemic neurological condition. I think then it's more useful to involve the neurologists. All right, so, excuse me. I see there is a question before I go on. So the question, is there any benefit in any other imaging types apart from MRI? Oh yeah, so we sort of spoke about it. MRI is hard to arrange as GP due to lack of Medicare rebate. And I think that's probably purposely been done by Medicare to try and cut down on the amount of MRIs done. So thanks for the question. I think I've sort of answered it before. Yeah, I think for your younger patients, you probably rather, if you are worried, you probably want to get an MRI. And maybe for your older patients, a CT scan could be useful. I mean, CT scan is perfectly good for looking at disc bulges. You can diagnose a radiculopathy on a CT scan. There's some things that you can't see on a CT scan, especially in your younger patients. You can't look for stress fractures unless there is a full fracture line. So yeah, for the most part, MRI is going to be the most useful. If that answers the question. So in our case, I think given his age, his activity level, I think it's reasonable to consider some blood tests just to rule out inflammatory arthritis with that history. Probably, like, realistically, in my practice, I probably would do an MRI because he's a fast bowler and they get a lot of stress fractures. And apart from that, you can justify not imaging him because it's probably not going to immediately change your management, but I probably would image this case. And then once again, I would probably just caveat that by saying, look, these are the things that aren't relevant, but this is what I'm looking for. I thought it might be helpful just to sort of quickly go through when we look at MRI scans, what are we actually looking at? So the first two slides, I'll show you sort of the main sequences I look at. I won't go into the detail of what's T1 versus T2. Generally, you want to find the scans where fluid is white and bone is dark gray. And that's your fat suppressed images. So on these ones, you're looking for areas that are white, and white is typically the abnormality. The one next to it is what's called a stir or a coronal stir. So now we're looking at the spine in the coronal plane, and this is obviously the sagittal plane. So I always start by looking at the sagittal, getting a sense of their alignment. You can see clearly the two discs that look abnormal are the dark ones. So compare that to L5S1, L34, where the disc is nice and plump. It's got lots of fluid inside the disc. You see these discs look a little bit darker. There's a little bit of end plate changes, that sort of early modic changes, and same thing at that disc level. Now, that could be coincidental. I doubt that both of those discs are painful, but you sort of pay attention to, okay, that's sort of the level you're concerned about. That might be relevant. You can look sagittally whether there's any central stenosis. Then I look at the coronal stirs, especially my young patients. because that's where you're most likely to see a stress fracture. So in these little areas here, the pars, in the pars regions, if you see the bones really bright, and I've got an example of that a little bit later. Then I always look at my axials. I do it on the computer, so I can have my sagittals and my axials together, and I can sort of keep an eye at what level I'm looking at. And on the axials, it's the best view to sort of get a sense of the shape of the disc. So you can see how this disc is bulging more to the left side than the right. So we'd say this is sort of a posterolateral disc bulge. It's not quite pushing on any nerves, but you see it's sort of encroaching on that nerve that passes past it. You can see there's still plenty of space in the neural foramen, so a lot of fatty space there. So it doesn't look like you getting any issues in the space, but potentially you might get some irritation there. In the axial views, you can also get a nice sense of what the facet joints look like. And the facet joints are these little hamburger-like structures. And typically you expect them to be fairly uniform. This one, there's a little bit of fluid, which is probably physiological. So this one, maybe a little bit irregular. So there might be some early facet changes. And then the next sequence, which is probably most useful for your young athletes again, it's either called a vibe sequence or a thrive sequence. So if you look up in the top corner where they describe what it is, it'll say something like T1 vibe or something to that effect. And essentially what they are, it's a certain sequence that allows you to look at the bony structures in a bit more detail. And what you can do is you can actually get the computer to flip it black to white. So then it ends up looking like a CT scan. And so especially with some of your modern magnets and your modern software, the MRIs are starting to become almost as good as CT scans at looking for bone. And so for most of our young patients, you wouldn't need to use a CT scan on them anymore. So in this case, you're just looking at those posterior elements to see if there's any disruption in the cortex of the bone. Sorry, I see there's another question. Yeah, so the question is, if there is a cancer history, what imaging would you start with? I suspect probably depends what cancer history, but I'm assuming if it's something where you're worried about bony metastases, then I think once again MRI scans going to be the most useful. You could see it on a CT scan. You might not see it on an X-ray. So I think in our practice, if someone warrants imaging, so they meet all the rules where you think it's going to change their management, there's a red flag, there's a specific cause you're looking for, then once again your MRI is going to be your best imaging modality. I think if resources are limited, then probably CT scan would be your next best. And then obviously depends on the cancer history. If it's something active, you're probably going to discuss that with the oncologist, and they might get your PET scans and things like that. All right, so a few examples. So this is another example of a disc protrusion. Once again, you can see it on the sagittal views. You can see the disc immediately at first glance looks different to the other discs. It's a bit dehydrated. It's bulging. So in the sagittal views, you can see it bulging. You can appreciate on the sagittal views how the S1 nerve root that has to pass past the disc is being displaced. And in the axial view, you can see the same thing. You can see how that disc is bulging posterolaterally, and the nerve that runs there is sort of having to curve around it. So, reasonable chance that they're getting some neural irritation from that. This is an example of a disc extrusion. Now you can see that little disc content that the radiologist has measured, you can actually see how it's popped out through the bottom of the disc. So that annulus is no longer continuous onto the bone. There's sort of a little interruption, and that disc material is just sort of popped out there, and now it's sitting there. So they're going to get probably quite severe pain. Often these ones can actually clinically resolve a little bit quicker than the more contained protrusions, because once again, the body's going to recognize that as foreign material and sort of gobble it up a bit quicker. And in the axial view, you can see the size of that extruded material, and you can see the nerve is running right next to it, and that's probably going to get irritated. This is a good example of facet arthritis. You don't often see it this clearly. I think it's fair to say if you get a case like this, you can probably with a little bit more certainty correlate that to their clinical findings. So the facet joint is this structure seen sagittally. You can see how the joint itself looks irregular. There's not much cartilage in that space. If you, sorry, you don't have another view of the other joints, but you can see there's a little bit of sort of cystic changes, and the bone around it sort of lights up a little bit. Seen on the axial view, once again, you can see you don't have the gray cartilage in between like you do on that one. There's a little bit of fluid. The joint itself is thickened and irregular looking compared to the one next to it. So that can cause sort of facet-related pain. It can also narrow the neural foramen and can impinge on the nerves where they go out there. This is an example of sacroiliitis. So this increased signal that you see on the coronal stir around that sacroiliac joint. So with them, you're going to sort of probably assume it ends up being some sort of inflammatory type of arthritis. This is a stress fracture in the lower back, or spondylolysis. And the first view you always look at with these is this what's called the coronal stir, which is a front-on view where the fat is suppressed. And you can see how the bone on the right side lights up compared to the bone on the left. If you look at it in the sagittal view, you can see how bright that bone is. And what we do in the clinic is for our athletes when they have these stress fractures, is there is a little measurement we can do using the computer to measure relatively how bright is that bone compared to the normal bone. And we describe that as a ratio, and we can actually use that ratio to determine whether it's getting better. So for instance, Cricket Australia, they would do serial MRIs on their players. They've obviously got a lot of money, and for them it makes a difference if a fast bowler gets back without a recurrence versus getting back and then having a recurrence. So they're happy to pay for them to have a new scan every 6 weeks, and they'll actually show that bone edema reduce in intensity. This is an example of a fracture line seen on that vibe sequence. So it looks like a CT scan. You've got that little Scotty dog appearance, and you can see the little crack, the little collar of the Scotty dog. And there's the joint above, joint below. That's sort of the classic space where you see the stress fractures is between the two joints in the pars interarticularis. So this is our case. So we've sent him for an MRI scan, and the most relevant finding is this sort of changes of the L5S1 disc. His bloods were normal. You can see it's sort of a broad disc bulge. It's not definitely pushing on the nerves. It's probably narrowing the lateral recess where the nerves have to run. From the sagittals, it doesn't look like it's displacing the nerve. So we're thinking most likely, given his history, given his age, given his scans, the disc is probably going to be the issue. Once again, I always caution rather err on the side of just treating mechanical back pain and treating what hurts rather than saying, oh, this is your L5S1 disc. We see a lot of patients who come in and say, I've got a slip disc, or I've got a so that message can often get stuck with them. So but for sort of my management, I'll probably go, look, it's probably the disc. So I'm going to look at the activities that put the most strain on the disc, and I'm going to modify that for the patient. So yeah, I mean, I would say my working diagnosis, to be safe, you can just say, look, you've got non-specific mechanical back pain. We've ruled out the bad stuff. It's probably disky. It's probably going to be worse with those flexion activities, and we're going to have to modify them for a bit. Once again, it's less important to be precise about the specific injured structures. We tend to approach managing these patients, and I'm not going to touch on management just because it's a whole different talk, but the way we approach management from a physical point of view is try and get a sense of what are the movements and activities that really sensitize their pain, and try and back off on that for a while just to reduce the sensitization. And in this case, you're probably going to modify things at work. You're going to modify sport. You're going to start some core strengthening exercises. You might look at trying to manage his pain through medications, physical modalities, and exercise. In his case, there'll probably be a limited role for intervention. Certainly, surgery wouldn't be recommended for back pain, and cortisone injections aren't particularly helpful for discogenic back pain in the absence of nerve root entrapment. I just wanted to touch on a few special considerations before we finish up. So there's a few caveats to the rules that we've already sort of touched on that I'll just go through. So firstly, your adolescent athlete. So, you know, if it's an active young patient, I think it's generally prudent to get imaging because stress fractures are so common. So if someone, the stats are that about 30 to 50% of adolescent athletes presenting with back pain will be due to spondylolysis. It's reasonable to just treat it as a stress fracture without imaging and assume it is, because you're going to get them to stop bowling or stop playing tennis, and you're going to take them through the rehab. And worst case scenario, if it's not a stress fracture and it's just mechanical back pain, that treatment's going to help them anyway. So it's not to say that you should scan them, but often the expectation will be, look, they don't want to just miss sport for 6 weeks or 8 weeks or 12 weeks for back pain that doesn't need it. So often with these, they'll sort of probably want some imaging, and then MRI scanning would be appropriate. With your adolescent athletes, have a high index of suspicion for inflammatory arthritis. So if they've got a lot of morning stiffness, if they've got other joints that are painful, if they've got a lot of tendonitis or enthesitis, you start considering working them up for inflammatory pain. The young patients with disc protrusions or disc bulges, where the disc is the source of the pain, can be really difficult to manage, and often have a higher rate of requiring surgery than your older patients. And I do find that can be a really challenging population group to treat. And with athletes, young athletes in general, sometimes the biggest problem is trying to get them to sort of pull back a little bit from their sporting activity. Now, for most of your mechanical back pains, they don't have to stop completely. You can usually keep them active, but you just modify what they do. You can get them on a bike, get them doing their core exercises and weights. You just take away the offending activity. With athletes in general, which we obviously see a lot of, always consider what they do, what sort of sport they play, what are the likely issues. Rowers all get back pain, and they can get quite severe discogenic pain. They can get facet joint pain. They can stress fractures. So these sort of athletic populations actually have a higher incidence of mechanical back pain, but they do also tend to respond really well to modifications in their training, reassurance, and they often are the most satisfying back pain patients to treat, because they do typically get better because they're all motivated to work hard and do their rehab and get better. Once again, the challenge with them is often just getting them to pull back a little bit. We've touched on stenosis. I think when you start getting your patients in their 60s, 70s, 80s with sore backs, and they're starting to get that, excuse me, pain down their legs when they walk, that's often due to stenosis. And they'll typically say it's worse when they're walking down hills, it feels better when they lean over. Often if they sit down for a few minutes, the pain will go, and then they can walk again. They may have associated numbness or paresthesia. And so the vast majority of these will still respond to rehabilitation and a walking progression, but some of these will actually require surgery. So once again, this is the group where you may consider imaging if they're getting that real sort of neurological type symptom. So back to our case. So after initially he responded quite well to a little bit of rest, bit of rehab, he comes back because he went back to work, and now he started getting this sharp lancing pain that's sort of shooting into his buttock every time he bends forward to pick something up. He's also noticed that his calf is feeling a little bit weaker, and when you test him, he's not quite able to do a single leg calf raise on that side. And you check his reflexes, and he's actually lost his ankle jerk now. And then, when you test him closely, you find that he's lost a little bit of sensation on the outside of his foot. And so you've now got to change to a likely more specific type of pathology, and you sort of re-image him. And what you find is now he's got a more significant disc protrusion that's starting to impinge on the descending nerve root. And now you're going to sort of change tack, and you're going to start treating him for the radiculopathy. So that's just an example. I mean, this is an example of an actual case, and it's just a reminder that, always go through this when you see the patient. Just because you've made a diagnosis doesn't mean you were right the first time. It also doesn't mean things haven't changed. So if someone is not responding as you would expect, or certainly if they're reporting symptoms that weren't there, then you've got to revisit the whole thing. If someone who you've been treating for mechanical back pain suddenly comes in and the pain is worse and they're having fevers and stuff, you've got to maybe step back and go, okay, maybe I should now image them, or I should do some blood tests. So every time I review a patient, I do a quick check for red flags again. I do a quick neurological examination. I think those are the things you don't want to miss. So in our patient's case, the management changes. You may look at a cortisone injection. If pain is severe or weakness is progressing, you may even have to refer him for surgery. When should you consider referring? Definitely if there's red flags requiring specific specialist treatment, they should be referred on as soon as possible. Anyone with radiculopathy with progressive weakness, that's an indication for surgery. And if you delay surgery, that weakness can become progressively worse and become permanent. So always check neurological examination, and if the weakness is progressing, you should refer them on. I think if someone's in severe pain that's intractable. Now, as I said at the start, the severity of pain doesn't generally mean that there's something serious going on. It might be a pain management issue, but I think if you are struggling to get their pain under control, certainly before you tempted to give them opioids, consider getting a specialist review on them. Anyone with sort of these persistent pain conditions, I think if you think there's a lot of central pain amplification, a lot of yellow flags, as I said, you may want to involve a pain physician or a pain clinic. If someone's got more specific structural issues, radiculopathy, stenosis, you can send them to a spinal surgeon. We obviously see a fair few back pains. We typically deal more on the activity modification and exercise prescription side of it. So the more challenging cases, I'll often refer on to a pain physician to sort of manage the pain, and I'll consult more on how they rehab, how they exercise, we'll maybe work with the physiotherapist. Obviously, we see a lot of athletes with sore backs. And the more sort of simple presentations of back pain, or even the early sort of not severe radiculopathies, we'll manage. In summary, I think history examination, by the end of that, you should have a fairly good idea of what you're dealing with. Imaging predominantly for red flags. Most of the time, your imaging is not going to have a big impact on how you manage the patients, unless there's a red flag or specific cause of their pain. If you are imaging, I always believe don't order a test you can't interpret. If you are sending them for imaging, have some idea of what you are hoping to see or what you are hoping to rule out, so that when you look at the scans, you can say, oh yes, they've got a stress fracture that fits, or I just wanted to make sure that it's not the nerve being trapped, that it's more the hip or something. So know what you're looking for when you look at the scans, and always do a neurological examination, even if you don't remember anything else. We're not going to talk about management tonight because it's a very complex topic. These are really good resources. So for those of you who see a lot of patients with back pain, or a lot of patients with chronic persistent pain, these are I think the best resources. The Explained Pain second edition is super user-friendly for doctors and for patients. It's by the Neuro-Orthopedic Group in Adelaide. The one of the authors of that book, Lorimer Mosley, has also got an excellent website called tamethebeast.org, and that's probably one of the first resources I give to any patient with more severe pain issues. There's a very good website from the Western Australian Health Department called Pain Health. That's got a good little 8-minute read on back pain that I give to all my back pain patients. And it's just got some myths and some facts about back pain. And New South Wales, the Agency for Clinical Innovation Pain Management Network, has some excellent modules that you can give patients with short little 5-minute videos on different aspects of explaining pain and managing pain. And then for those of you who are really interested in understanding back pain and the mechanics of it a little bit better, I think Stuart McGill's book, Lower Back Disorders, is a really good resource. He goes into a little bit of the biomechanics and the structure of it and how different movements affect the back. So if you see a lot of backs and you're interested, that's a good book. This is our clinic over at Moore Park, just behind the SCG that you see in the background. We've got a number of sports physicians and a couple of sports medicine registrars. Dr. Morgan's just finished qualifying, so he's a sports physician himself. Dr. Cooney is our current registrar. So if you ever have any sports medicine needs, feel free to reach out to us. Got some time for questions?
Well, thank you very much, Etienne, for a very comprehensive discussion on assessment of lower back pain. If there's anyone got any question, please don't hesitate to put it through the Q&A and we'll attempt to go through them. Can I just start off asking just a couple of questions? Yeah, I noticed that on some of your slides you mentioned about stress fracture, especially in young people or young athletes. I just want to ask you, is there any place regarding, especially in view of GP, in terms of ordering and resources about ordering MRI, do you see any role in terms of the good old days we use bone scan and or is this, but I understand it because radiation level obviously a lot higher in a younger person we need to be conscious of. But I just wonder, do you ever order bone scan for that sort of
I haven't. Yeah. I haven't for a long time. Mainly due to the sort of concern around radiation, but it wouldn't be a bad imaging modality because it certainly would light up. And you know, back in the day, we did used to occasionally get bone scans for them. Sometimes where it gets tricky is, and this is probably more for your sort of 20-year-olds, 20 to 30, where they could have a little bit of facet arthritis. And even the good CT specs, they can't quite put the hotspot, whether it's on the bone or on the joint. So that can sometimes be a little bit tricky. With MRI, you don't really have that issue so much. But yeah, if you really don't have the resource, if you don't have access to an MRI, and that's all you've got, and it's going to significantly change your management, then bone scan would be reasonable. Definitely bone scan over CT. I think CT scan's only going to show about 10 to 20% of them. So, you know, you'd want to combine that with the bone scan or SPECT.
And I suppose following to that question will be in terms of looking at the improvement of that stress fracture. I mean, obviously, with people playing elite sport, the sport club will pay for their MRI to look at the healing of that. What would be? I mean, I guess by the sound of it, MRI seems to be the modality of choice, really. And can I ask, in terms of general community, let's say someone can afford to play MRI, what sort of time frame would you perform a repeat, a follow-up, or serial MRI, especially in terms of looking at stress fracture, looking at letting them know, you know, apart from symptoms, when they can return to sports?
Yeah, I mean, this is a really good question because we do have, you know, for a lot of these sporting organizations and probably even the demographic I work in, you know, there is access and resources there, and there's a lot of debate as to how useful serial MRIs are. I go through phases where I'm, you know, think, oh, maybe it is better if you see it heal. Other than cricket, there's no real evidence that waiting for it to heal leads to better outcomes. Cricket's argument is that, you know, it is an injury that's prone to recurrence, especially in their cohort, and the ones that recur are probably ones that hadn't fully healed and got back too soon. But I would say for the general athlete, I generally don't do serial MRIs. unless they're not responding. So I wouldn't do follow-up MRIs. I would go clinically. I do a sort of a clinical progression. I wait till they're completely pain-free with daily activities. Then I might get them to start some light cycling where they're in a flex position. And they might start a little bit of core exercise with a physio. And then after another 4 to 6 weeks, I might see them again. And if they're completely pain-free, I might get them to start a bit of running. And so if every stage they get through that without a recurrence of pain, I'm very happy for them to get back to sport without repeat imaging. Where I would then sometimes consider it is if they've been back running for a few weeks and now they're getting sore again, and you're worried that they've had a re-aggravation or a relapse, then I'll sometimes scan it. And often then the scan will be clear, and then you go, look, we can keep pushing here. Or if it's sort of bright, then you have to pull them back. And it's once again easier with the athletes to pull them back when you've got the scan to sort of back it up. But there's no good evidence that serial MRIs are necessary to safely return someone back to sport. 9 times out of 10, good clinical progression is the safest way. And even I've had athletes where I've scanned them 4 times and just watching this crack not heal, and eventually gone, you know what, let's just go because you're pain-free. Most of them will go on, they'll get a fibrous non-union and it won't cause any issues down the track. So even the concept of truly needing the bone to heal for a good outcome hasn't been proven.
Oh, that's good to hear. So basically, treat the patient, not the pictures.
100%, yeah.
Absolutely. I've got just one question here from, I don't know where you can see that. Here's this mention about, one of the participants mentioned about an older person had a fall and had chronic pain. Is it automatically a red flag due to the trauma, or would you only consider imaging if they have increased the pain or change in function, neurological changes?
Yeah, look, I think if it's depends how chronic, but if it's been months, once again depends how severe was the pain, what are the the risk of osteoporotic fractures. It probably all depends on that. I guess if they've had an osteoporotic fracture 4 months ago, is there much you're going to do about it now in the absence of neurology and they're getting better? Probably not. Maybe at least just do an X-ray, and it might be someone with osteopenia. Now you X-ray them and they've got a fracture, and you say, well, actually, now they've had an osteoporotic fracture, so it changes the treatment of that. So I think probably from the point of view of managing the osteoporosis, it's probably useful to get some sort of imaging. We got a question: how would you differentiate early signs of ankylosing spondylitis and back pain? I think there's no easy way to do it. I think it's really you just got to suspect it. So I think your history of early morning stiffness, if you've got a suspicion, do a thorough examination to look for your extra-articular manifestations, checking their nails, checking for psoriasis, asking about history of inflammatory bowel disease, asking for family history, asking about other joints, examining the tendon insertion, seeing if they've got enthesitis. So you basically do a more clinical assessment of whether there's other signs of inflammatory arthritis. But last time I checked, I think the average time to diagnosis for ankylosing spondylitis is like 8 years. So the reality is, in the early stages, even if you strongly suspect that, all the tests might still be negative, and you can't make that diagnosis until you actually see the sacroiliitis, or until blood tests confirm it, or they've got some other manifestation. So I think it's just about suspecting it, at least screening for it early, telling them that you haven't definitively ruled it out, that if down the track things change, you might repeat some of those tests, and keeping that on your list of potential diagnosis, and just remember, you can never really rule it out with 100%. I think that's probably most important.
Great. I think I saw one, not so much of a question, I think it's just more of a request. I think one of the participants was asking about the slides that you have presented to us this evening. Would you be okay for us to make it available for participants to review it later on?
Okay, that's fine.
Lydia, I presume.
Yes, we have a copy, and it will be sent out in follow-up email Thank you. All right. Thank you, everyone, for attending tonight's session. Very comprehensive and very relevant to general practice. Thank you to our speaker, Dr. Etienne Dupree, and our facilitator, Dr. Kenneth Tong, for your time. And thank you, everyone, once again.